So hello everybody, this week's teaching will be on cardiology emergencies aimed at preparation for starting work. So I will let you go ahead and start.
Brill. Thanks, Steph. Yeah, so today's teaching on like cardiology sort of emergencies and common cardio presentations on call. So I'm an FY1 at Wythenshawe Hospital, so I've done one medical rotation and this is my second medical rotation, so hopefully this presentation is of some benefit. The plan is that I'm just going to basically go through an A to E assessment first, and then followed by a couple of scenarios to see how common scenarios that you would get as an FY1 and see how you sort of deal and go forward with that. Okay, so common presentations on an on-call. So I've listed a few here. These are probably quite common, certainly from my experience, sort of like chest pain, shortness of breath, palpitations, hyperkalemia, definitely dealt with loads of that, syncope, high early warning score. Just generally when a patient is scoring, often you get bleeped, you know, to assess the patient and see what's happening. But yeah, these are definitely the sort of presentations you get, certainly from a cardiology perspective. And there's probably some overlap here as well with like respiratory and other stuff as well, with like chest pain, could be of cardiac nature, could be of respiratory, could be anything else as well. You definitely get massive overlap. But yeah, from a cardiology perspective, these are sort of things that you often get bleeped about. Okay, so before going into the actual sort of like assessment and actual scenarios, I thought it'd be good to just talk about the basic process, at least what happens, at least the process that I go through when sort of dealing with on call when I'm bleeped. So often like, for example, when you're on ward cover and you know, you get bleeped by a couple of different people, different nurses from different wards, you have a number of jobs. So you're bleeped, and what I do often is just grab a piece of paper and write down the jobs. So I'll write them down, write where they are and what needs to be done, and then that allows me to sort of prioritize the jobs. So for example, if someone in, I don't know, such a ward needs a cardex rewriting, that's probably not very high on my priority, whereas someone who's got new onset chest pain sounds like cardiac chest pain in nature, and that's probably going to be high on my priority list. So always write down, and I always use that to prioritize. And then when I'm being bleeped and say the nurse is asking me on the phone, you know, about like she wants me to review someone with chest pain, I always ask a few questions. Firstly, I sort of ask, who is the patient? How old are they? Why are they in? Almost like a sort of a mini S-bar, so you know what's going on. Often you find people just tell you, oh, someone's got chest pain, but it's just nice to have a bit of background. What are they scoring? Because this will tell me really how unwell they are. If they're not scoring anything, it doesn't mean I don't need to review them. It just means that I'm not as worried about them as I would be otherwise. But if they're scoring high, let's say they're scoring a 5 or a 6, they're, you know, the blood pressure is dropping, the tachycardic, that sort of thing, they're going to have a high score. So then I know that, you know, I need to see this patient quickly. So I always ask what they're scoring on the OBS and what the OBS have been like. So just getting a background and sort of getting what the OBS are, what the early warning score is, gives a good picture, and again allows you to prioritize as well what you need to do. What you also can do is and this I guess you'll pick up with experience, and certainly I've done with experience, is that when I get bleeped, so for example someone has chest pain, it sounds like cardiac, or someone's, let's say, tachycardic, I ask the nurse on the phone if they can do an ECG before I get there. It just always saves time, and sometimes I even ask them to sort of repeat the OBS, and it just saves you some time. When you get there, you've already got some sort of like, you've already got an ECG there, or you've already got, you know, fresh OBS there ready. Whereas if you get there and then you ask for them, then, you know, you can be, you're standing around for a bit. So it can just help sometimes to ask for a few things on the phone. When I'm on the way to the patient, I'm sort of going through the differentials in my head of, you know, what it could be. So if I've got a call about chest pain, then I'm thinking, you know, could this chest pain be cardiac? Could it be respiratory? Could it be musculoskeletal? What are they scoring? I'm sort of going through in my head, sort of like a thought process of what this could be. And I'm also thinking about how I'm going to assess the patient. And so when I get to the patient, then obviously I have a quick look. I already know the background, the history, that sort of thing. and just see what the patient looks like from a distance. I've not yet spoken to them. I'll just sort of like end of the bed, sort of see what they look like. Are they really, do they look pale? Do they look dehydrated? What is their status of what they can look like? What are they looking like at the moment? And then sort of start the A-to-E assessment. And that's really sort of probably the main thing from this, to take away from this presentation really, is that when you approach the patient, you've spoken to them, doing an A-to-E assessment. And this is sort of, whether you know what's going on or you don't know what's going on, this is probably the only and the best approach to do. So quickly go through the A-to-E assessment first.
Just to briefly add, so the intervention as well, you can ask them to do other things, because obviously they can put oxygen on. If they've got known ischemic heart disease, they can try a bit of GTN, just think about what the nurse staff are able to do as well. And there might be some other things they can do to help, in certain situations. And initial inspection is a really good one, because it actually does give you such a good overview of what the patient is like. And I think you can go with your gut instinct, can't you, a lot of the time? And often your gut instinct is right. Bobby said, can you give GTN over the phone? Of course you can, yeah. So especially if they've already got it prescribed, even if they've not got it prescribed, you can say, I'll prescribe it when I get there. Why don't you try them with a bit of GTN and I'm on my way? If they've got cardiac sound and chest pain, it's not going to do them any harm to try a bit of GTN until you get there. So it's always a good one to think about. If some people are really hypotensive, even you can ask them to give fluids and things, but that kind of comes a bit more with experience, because obviously there's lots of reasons why somebody might be hypotensive. But all the things to just think about, really. Let you go on.
Yeah, definitely, Steph. Yeah, definitely. I mean, even I think some nurses on AMU, they can take bloods as well. So sometimes you can just ask them to sort of like take bloods and that sort of thing as well, from my experience of what I've seen. And definitely 100%. There's a lot of interventions that you can do before you get there through the nurses, etc. Okay, so going on to the actual A-to-E assessment. So airways, breathing, circulation, stability, exposure, and I'll go through each one briefly, just talk about them in turn. So coming on to the airway first. Anyone tell me anything about the airway? Anything about the airway? How do you assess it? Anything?
Look for obstructions.
Pardon?
Look for obstructions.
Look for obstructions. Yeah, definitely. That's very important. Yeah. Anything obstructing the airway. Absolutely. Anything else? Yeah, so you mentioned obstructions. That's very important. How do you tell the status of the airway? You do an initial assessment. If the patient is speaking, then sort of like the airway is patent, because they wouldn't be able to speak if the airway wasn't patent. So obviously them speaking and talking to you is a very good sign. Are there any sounds that you can hear? Are there any noises that you can hear, such as sort of like stride or snoring? Anything of that sort, that will give you an indication. Is there a blockage, or is there an obstruction somewhere that's preventing them, obstructing the airway, making that grunting noise, that sort of thing. So there we go. Stride or gargles, snoring, and you mentioned sort of obstructions there. Are there any visible obstructions? This could be foreign body, could be vomit, could be some blood, and this can be. You can use sort of like suction or forceps to remove this sort of obstruction, but I'll go into more sort of what you can do about the airway. So in terms of airway management, what can we do for airway management? If we're suspecting the airway isn't patent, what can we do? What interventions can we do, or what can we do when you get to a patient, you think, they're not responding to you, the airway, you might, you can hear some noises, some snoring, some stridor. What are you going to do? Any suggestions? Are there any maneuvers we can do? So common maneuvers we get taught in ALS, adult life support, when we do A-to-E assessment. So the common thing that we do is a head tilt and chin lift. And we can also do a jaw thrust as well. And this sort of often relieves any sort of anything that's obstructing superficially at least, the airway. So a head tilt chin lift is one of the main things you can do. You can do a jaw thrust as well, and you get taught that in ALS as well. And then there's some sort of like devices or adjuncts that you can use as well for the airway. And there you go, they have listed some there. So you can use a Goodell, which is an oropharyngeal airway. You measure it from the incisors to the mandible. You know, you can use that. You can use a nasopharyngeal airway that's measured from the nostril to the earlobe. It's usually longer, and you can insert that as well. And often these airway adjuncts are present on the emergency trolley. There's an example of Goodell's. They come in different sizes as well, so you can just measure them, as I said before, from the incisors to the mandible. And there's a nasopharyngeal airway, and they also come in a couple of different sizes that you can use. So that's basic airway management there.
And obviously, if you feel like you can't manage this, then obviously call for help. Yeah. Which it might be anaesthetics, or it might be just that, you know, someone more senior. I don't think you'd be expected to know all of this straight away when you start. So just call for help.
Yeah, definitely. And that's probably the other big point to hammer home, is that certainly initially in my first, second rotation, I've always, even for, you know, quite small things, when I'm unsure, I'm always briefing seniors and asking for sort of help or what to do, or asking for help. And
now, as a more senior, we don't mind. we'd rather be to talk about it, and than let you feel like you're on your own.
Definitely. Okay, so moving on to breathing. Right. Does anyone want to say anything about breathing? Can you tell me anything at all about breathing? Anything you know about breathing whatsoever? Anything about breathing at all?
Check respiratory rate.
Yeah, definitely, absolutely, definitely a big one to check the respiratory rate. So normally the respiratory rate is between 12 and 20. So if you know it's not within that range, then you're a bit worried about what's happening with this person's breathing. Anything else? Any other signs? Any other observations to look for in breathing?
Shortness of breath.
Yeah, shortness of breath is something good to look for. Yeah, so initially when you sort of assessing the patient, when you're speaking to them, are they short of breath, that sort of thing, that can give you an idea about their breathing. You can even just assess their sort of muscle tone or sort of their pattern of breathing and see how that is as well. And then I think you mentioned already respiratory rate. The big one to check in breathing is oxygen saturations, and the normal target is between 94 and 98, unless you're a patient with COPD with CO2 retention, but generally it's 94 to 98%. So oxygen saturations are the big one. Is the trachea central? How's the chest expansion? You can do some percussion as well, and you can have a listen with your stethoscope as well. Are there any crackles, wheezing, that sort of thing? So there we go. There's some examples of what's involved in breathing. You can do some interventions here as well. So just, you can order a chest X-ray. You probably wouldn't do it immediately within the AT assessment, but it's part of your thinking about what you want to do with this patient. And then
absolute main breathing. Yeah. What is an absolute main breathing thing that people want to rule out that could kill someone if you don't do anything about it? Anyone know? So it'd be a tension pneumothorax. So, lots of these other things, you can deal with, you can take your time, to be honest, can't you? That's one of the other things about once you start working, you realise you've got more time than you think you've got. But one thing to make sure you don't miss is a tension pneumothorax. So is the trachea devigated? Can you hear breath sounds? And what's the percussion like? Everything else after that, you can take your time to kind of figure out what's going on.
Yeah, definitely. Yeah, so definitely tension pneumothorax, and then you can gather that from the signs like Steph said, checking the trachea, checking the breathing sounds, etc. So yeah, these are the sort of things that are involved in the assessment of breathing. And then the things you can, or the interventions you can do for breathing is that if they're desaturating, obviously put oxygen on. At an FY1 level, I think it's just completely fine to, if they're desaturating, let's say, quite low, below 90, to put 15 litre non-rebreathe on as a sort of like a first sort of intervention. I think that you'd be expected to sort of be able to do that. So you can also position the patient as well, sit them up. Depending on what you think is going on, you can give them, prescribe some nebulizers, some salbutamol if there's like an acute exacerbation of asthma, ibuprofen bromide, that sort of thing. But yeah, there's just some examples of management you can do in breathing. But yeah, like I said, the main thing is for you to be able to recognize that the patient is desaturating and give them oxygen. Okay, so that's breathing. Then moving on to, and there's an example of a non-rebreathe mask. So you've got Venturi masks, you've got nasal cannula that are just in the nose, but this is a non-rebreathe mask, and that's what it looks like. Okay, moving on to circulation. So what's involved in circulation? Can anyone mention anything? Any ideas?
Blood, fluid.
Yeah, exactly. Yeah, fluid status. Yeah, assessing the patient's sort of blood pressure, checking their fluid status. Definitely. Anything else? Yeah. Okay. So in circulation, essentially, you're checking. You can start by checking the capillary refill time. You can check the pulse, the blood pressure. I sort of like working my way up the arm. So if you start sort of like the finger, you can cap refill, heart rate. You can check the pulse, the radial pulse, and then you can move on to the arm, which is blood pressure. So whenever I think of like sort of circulation, I think of the arm and sort of like work my way up, and it just reminds me of all the sort of like things to look for in circulation. So yeah, so check the pulse, check the blood pressure, check the urine output, if it's been monitored, see have they got a catheter, that sort of thing. What's the temperature like? Then you can do some additional things such as look for the JVP. You can listen for heart sounds, that sort of thing. And I've listed them here. There you go. So that's what's involved in circulation. And then coming on to sort of a circulation management, what can we do in circulation in terms of what can we do to the patient? So you've come to see a patient who's acutely unwell. They haven't really had anything. You do a quick AT assessment, you reach C. What is it that you want to do? Is there anything particular you want to do in C? So it's very important to gain IV access. I would always sort of like, look, has the patient got any cannulas in, and gain some IV access. And particularly if they're unwell, they're desaturating, they've got a temperature, that sort of thing. Take some bloods. Very important to take some blood. So you can put a cannula in and just take some bloods through the cannula. You can take some blood cultures as well. If you think the patient is sort of like, if their blood pressure is dropping, if the blood pressure is low, then you could also give some fluids as well, like a 500 ml sort of fluid bolus of saline over 15 minutes, that sort of thing. So yeah, there's some sort of quick interventions you can do whilst you're doing the A to E assessment to sort of like, very important to sort of gain IV access and, take some bloods, that sort of thing. You could do an ECG as well at this point, and I mentioned the previous slide, you could do an ABG as well if you think the patient is sort of desaturating and needs an ABG. You could do an ABG at this point as well. So that's circulation. Coming on to D. Anyone want to add anything to disability? What's involved in this part of the AT assessment? What do we look for?
Mobility,
Sorry, Sally.
mobility aid.
Yeah, absolutely.
Some people have put in the chat blood sugar and neurology.
Absolutely, yeah, definitely. These are all part of disability, assessing disability in this. So yeah, so just checking the patient's consciousness using GCS or the AFPU score, checking the pupils, check the BMs, see what the blood glucose level is. I've mentioned temperature here, but you can check in the previous one as well. And then just some management within what you can do. So you can correct any sort of like low blood sugars, or if they're high, you think about giving insulin, that sort of thing, depending on what you're dealing with. You can give some pain relief as well. And these are sort of like interventions you can do in disability. Okay, so moving on swiftly on to exposure. Okay, so a couple of things here, just to look for sort of like any rashes, injuries, bleeding. Just have a quick look at the history, past medical history. Even if the patient is confused, that sort of thing, you can take a collateral history, that sort of thing. Find out what they're already taking in terms of medications. Have they taken any drugs, that sort of thing. And just checking their body for any sort of injuries, rashes, bruising, that sort of thing. And then to do the ATE assessment, again, you reassess, because now you've given some intervention. So you might have given some fluid, you've taken some bloods, you've given some oxygen. And so you reassess again to see, have the saturations improved? Is the blood pressure coming up? And then you can reassess after that. Okay, so that was a quick overview of the ATE assessment. So now the plan is just to do a couple of quick scenarios to sort of like of what happens on call, what sort of scenarios you come across, and see how we deal with them. So, okay, so the first case, we've got a 53-year-old man, past medical history of hypertension, angina, type 2 diabetes. This patient was had an operation 3 days ago for a right inguinal hernia repair. Now, day 3 post-op, the nurse tells you on the phone, as bleeped you, and tells you that the patient is complaining of chest pain. I forgot to write the obs here, but let's just say the patient's sort of like a tachycardic, like 105, blood pressure's like 170 over 90, that sort of thing. So that's the scenario. That's what the nurse tells you on the phone. Is there anything that you want to ask for on the phone before you get to the patient? Is there anything you want to ask? Anything particular you want to ask on the phone? So whoever's bleeped you has just said, we've got this patient, they're now complaining of chest pain. These are the obs. Will you come to see him? Is there anything you want to ask them on the phone to do?
ECG.
Yeah, ECG. Yeah, absolutely. Yeah. So you can ask them to do ECG, especially if you think that, if the chest pain is a cardiac sounding chest pain. You can tell them if the patient is tachycardic. You can ask for an ECG, you can ask for repeat obs, anything else that you think is appropriate to the scenario and you think they might be able to carry out, you can ask for on the phone, as I mentioned earlier. Okay, so going on towards so you go to the patient, you get to the 53-year-old man, and the first thing you do is you speak to him. So what would you ask the patient? All you know is that the patient's got some chest pain. Anything you want to ask?
I know this might be a bit long, but I would do like Socrates. I will cover all of it.
Absolutely. You definitely do that. I definitely do that. And it actually doesn't take that long as well. So you can just quickly ask them, yeah. So what sort of pain is it? Where is the pain? When did it start? Sort of, how bad is the pain? Has it gotten better before? Have you ever experienced it before? And is it worsening? Are there any other symptoms with it? What other symptoms would you look for? So let's say he's saying, oh, I've had this pain has come on 15 minutes ago. It's really bad. It's on the left side of my chest. It feels like someone's sitting on me. Anything else you'd want to ask, or any other symptoms you'd look for?
Shortness of breath. How long?
Yeah.
Have you got temperature?
Yeah.
Have you noticed anything associated with it?
Yeah. Absolutely, definitely. Yeah, so shortness of breath is a big one. Yeah, shortness of breath. Has there been any nausea, vomiting? Have you been sweating at all? That sort of thing. And so that sort of short history gives you an idea. Okay, now, so he's got left-sided chest pain. He's got a history. He's got a cardiac history. He's got high blood pressure. He's got angina. He's got this chest pain on the left side. It only began 20 minutes ago. It feels like someone's sitting on him. He's got some shortness of breath. He's a bit sweaty. You're pretty much thinking at this point now that it's a cardiac chest pain. And so now you start your A to E assessment that we talked about. So you do your A to E assessment. And so is there anything particular in the A to E assessment that you would do? So let's say, okay, so he's clearly talking, so the airway is patent. So you move on to breathing. He's a bit short of breath. you know, you check his saturations and they're like 91%, 90%. Anything you want to do?
Oxygen.
Yeah, absolutely. Give him some oxygen, yeah. And what type of oxygen would you give?
Non-rebreather.
Yeah, non-rebreathe, yeah. Yeah, absolutely. So give him some oxygen. So you go through B, you go through C, you take some bloods. Any particular bloods you'd want to take when you're in C for this patient?
Chops.
Yeah, absolutely. So you do the whole list of bloods, or the routine bloods anyway, and then you do a trop as well. Yeah, so you definitely want to do a trop.
Nadia put clotting as well in the chat, which is a good one.
Definitely, yeah, definitely. You definitely put in, you know, you could do a clotting screen as well, user needs, LFT, CRP, the whole sort of routine bloods, and then obviously your trops as well. Okay, so you go through C, you go through D. The patient's in pain, they're complaining of pain. Anything you want to give them?
Painkillers.
Yeah.
Analgesia, so Nadia's put as well in the chat.
Yeah, analgesia. Yeah, absolutely. So you could give some IV morphine. And I should have mentioned this earlier as well, but you should sort of give GTN as soon as you think is a cardiac type chest pain, really. So you can give GTN as well. And so you've done your AT assessment. And so these are the sort of the interventions, the particular interventions that are probably specific to cardiac sort of chest pain that you could give in an AT assessment. And then obviously aspirin for the antiplatelet, which is given for cardiac sounding chest pain. And so when you were in C, you asked for an ECG, and the ECG has come back and there's no ST elevation. So,
and you're like, thank God.
Yeah, absolutely. You're like, thank God, 100%. Yeah. So it's an NSTEMI because there's been a rise in the troponin. There's no ST elevation, but there's some other changes, such as ST depression, and if you leave, that sort of thing. So if that is the case, then you can give the second antiplatelet, which is ticagrelor, and you can give fondaparinux as well. I think that this is probably a bit specialist, but I just came across in my own call a couple of weeks ago that if they've got an existing arrhythmia, then you'd give clopidogrel, I think. But yeah.
So usually they give clopidogrel if they've got if they're on existing anticoagulation. So if you're on a apixaban or rivaroxaban or warfarin, they usually give clopidogrel instead of ticagrelor, and that's just because of their bleeding risk.
I see.
Bleeding risk is much higher. So yeah, so that's usually the reason why. So yeah, so immediate treatment, give the antiplatelets, give fondaparinux.
Yeah.
Then you might, if you know this is definitely ACS, you might also give like bisoprolol, ramipril, all of those kinds of things. But something you need to worry about on your acute on call. It would just be get the antiplatelets.
100%, yeah, definitely, yeah. So the main thing is definitely the antiplatelets for sure, yeah. There's also some, like, obviously, you know, by this point the patient would have had some GTN. You can give some GTN with saline as well if they've still got some pain. And obviously bleep seniors, you know, get cardiology to review, because they probably need a specialist review anyway. So
a kind of NSTEMI is usually a little bit less scary, I think, in real life than what you think it's going to be as a student, because you don't actually do a lot. Like, you just give the antiplatelet treatment, and then it's more if they've got ongoing pain or ongoing symptoms that then it gets a bit more like, oh, well, I've kind of at the limit of what I can do here. So that's when you're going to be seeking cardiology and senior advice. But the initial management is actually quite simple, because it's, you know, the morphine, etc., and then antiplatelets. That's it. So
yeah, absolutely, yeah. So yeah, exactly. It's not very complex to sort of manage. And certainly, even in when I've been on admissions, I've seen loads in sort of ED that you deal with NSTEMI, that sort of thing. Okay, so that was the sort of the first situation where you got an NSTEMI. This is the second situation. So can anyone see where's the ST elevation in this ECG? And for bonus points, if you could tell me which artery the infarct is most likely in. Any ideas? Anyone?
So yeah, Simon has said lead 1. So yeah, you're right, lead 1, there is a population. Anywhere else?
Oh, sorry, apologies. Oh, goodness me. Bear with me. There we go, sorry. Right.
The left descending artery.
Sarah's put circumflex.
Circumflex. You've got left descending artery. Anything else? So yeah, the correct one is the left circumflex artery. So if you think about where the leads are positioned on an ECG and where they're looking at the heart from, so the ST elevation is in lead 1, AVL, and 5 and 6. So if you think about AVL, it looks from the left. Lead 1 also looks from the left. V5 and V6 also look from sort of the lateral side. So this is a lateral MI, and the most likely artery is the left circumflex artery. So yeah, well done, guys. So that's an NSTEMI. Okay. Okay. So this is sort of like more sort of, I think, specialist management and more sort of like senior management within this one. They've got a STEMI on the ECG, they've got a rise in troponin, and you've given the antiplatelets. Sort of at this point, the main thing is to sort of escalate to the seniors. You know, get whoever's senior involved in, whether that's probably your reg or SH or whoever it is, get them involved. The patient really needs an urgent PCI, and you know, sort of cardiology need to deal with it. So yeah, this is probably more sort of like for senior management for this sort of patient. Okay, so second scenario, you're the night FY1, handed over by day FY1 to chase some bloods, in particular the U&Es for a 79-year-old man with a complex past medical history, and they're having their repeat U&Es to check their AKI, which has been improving in the last few days. So the bloods come back and the potassium is 6.2. So what are we thinking, guys? What's this? Potassium is 6.2. Is that normal?
Isn't that hyper?
Yeah, absolutely. That's hyperkalemia. Yeah, absolutely. That's hyperkalemia. So hyperkalemia, I think, so usually above 5.5. I think some places have it like above 5.3 or whatever. I think it varies a little bit. But yeah, generally over like 5.5 is hyperkalemia. Anyone know any causes of hyperkalemia? Anyone want to mention anything?
Adrenal insufficiency and kidney injury.
Yeah, absolutely. Yeah.
Medication can do that as well.
Definitely, all of them. Yeah, definitely. So Addison's disease, yeah, medications can do it as well. AKI, that sort of thing.
Yep, someone's put in the chat as well, diuretics, which is...
Yeah, absolutely, yeah. So there we go, diuretics, yeah, so spironolactone, potassium-sparing diuretics, ACE inhibitors as well. Sometimes it can be an artifactual result as well, sometimes. So what symptoms can patients with hyperkalemia get? Any ideas?
Ventricular fibrillation.
Yeah, anything else? So yeah, so you can get some different symptoms. I mean, a lot of the times, if it's not very high, they're probably asymptomatic, but you can get sort of like chest pain, weakness, palpitations, lightheadedness, that sort of thing. And yeah, the thing is to get an ECG done. It's important to get an ECG done, because if this ECG changes, then that might affect and probably will affect your management. So this is an example of an ECG with hyperkalemia. So does anyone know the features of hyperkalemia on an ECG? Or can anyone point out from this ECG any abnormalities? Let's have a look in the chart. Tall tented T waves, absolutely. Sinusoidal waveforms, yeah. Anything else? Does anything happen to the QRS complexes? Does anything happen to the P waves?
Wave absence.
Yeah, so you get flattened sort of P waves. And where can we see that in this ECG, or sort of like reduced P waves? Is that apparent anywhere here? Any particular lead? So if we look at sort of like V5 at the bottom, you can see that, you know, there's pretty absent or sort of flattened type P waves, and you can see these massive sort of like T waves clearly here in V4, V5, V6, and in V3 as well. So yeah, these are classic features of like hyperkalemia. Okay, so just going on to sort of then the management of hyperkalemia in the next slide. Yeah, okay. So again, you go to the patient. So let's say the patient's asymptomatic, you know, they're not showing any symptoms yet. They've not got any symptoms. You just know that their potassium was 6.2. When you assess them and take a quick history, you'd still do an A to E approach and an A to E assessment just to see if everything's okay and see if they're not acutely unwell at all. By the way, your documentation is also based on your A to E assessment. So when you do document the patient's history, etc., and when you document examination, I always document using the A to E approach. Okay, so you've done your A to E assessment, which the patient's okay. They're not on any oxygen or anything. They don't need any oxygen. You know, they don't need any fluid. The blood pressure's okay. It's just that they've got this potassium of 6.2. So what we're going to do? So usually, different hospitals will have different guidelines. Broadly, the management is the same, but there'll be sort of like minor differences in what they constitute as sort of like mild, moderate, and severe. Certainly in MFT, we've got sort of this sort of type of categorization where it's like, I think it's 5.5 to 6, which is sort of like minor, and then moderate is 5.5 to 6.5, and then above 6.5 or patient who has ECG changes, that's severe. And so for basically a patient with sort of mild hyperkalemia, all you'd sort of do is monitor the potassium, check it again. And by the way, you don't have to take a full set of bloods and send them off to the lab to check potassium. You can just do a VBG and just run it on the gas machine and check the potassium like that. It saves you a lot of time, and obviously you want to find out quickly what the potassium is, especially if it's higher and you've given an intervention to try and improve it. You can treat any underlying cause, stop any offending agents that you think are causing it. If they're on, I don't know, a very high dose of spironolactone or that sort of thing, maybe you want to reduce that, maybe hold it for now, that sort of thing. So yeah, that's it. That's for mild hyperkalemia. For moderate hyperkalemia, you give insulin and dextrose. So you give atropine 10 units in 50 mils or 50% dextrose. And then obviously you'd repeat the potassium sometime later. What is it like? I think it's a half an hour later. You can sort of check it or whatever, really, whatever's reasonable, and see if that potassium is improving. If they've got ECG changes, they might even be symptomatic and the potassium is really high, then you give the insulin dextrose as mentioned, you give calcium gluconate as well, you give some salbutamol, and I would escalate this, you know, to a senior and make sure they know that such a patient has got, you know, very high potassium and that sort of thing, and then keep monitoring the patient for their potassium, check their OBS, and a thorough AT assessment. Yeah. Okay, so that's hyperkalemia. Coming on to the third scenario. So 85-year-old man on a complex care ward with a past medical history of AF, type 2 diabetes, heart failure, gout, osteoarthritis. The patient's got known AF and they're usually just on some rate control with bisoprolol 2.5 milligrams once daily. Okay, so the heart rate is currently 130. It's not normally that high. Normally it's like 80, so it's controlled normally, and in this case it's elevated. So
Can I say, I don't know what you think, but this is probably one of the most common things with you as an F1, regardless.
Definitely,
this happens all the time.
Yeah.
So
definitely, very common. For sure. Very, very common. Yeah, come across it numerous times for sure. Okay, so I think I've put a few slides about AF. I might not go into too much detail about them because we've not got enough time. But basically, there's a definition of AF, and there's sort of your classification of AF. causes of AF, we've got cardiac causes, non-cardiac causes. In a patient who's got pre-existing, this is what I've not put this on the slides, but basically this patient's already got AF. So these are the causes of AF in general, but in particular, the patient's heart rate has just gone up right now, so the AF has been exacerbated. It might be something like hypovolemia or something of that sort, or any acute abnormality, an acute event that's triggered the AF to increase. So it's important to look out for that and correct that. Clinical features, yeah, you can get different sort of symptoms with it: chest pain, breathlessness, palpitations, etc. ECG for investigations, yeah, you do bloods, and these are sort of like more echo. You probably wouldn't do it there and then, but yeah. Okay, so this is a classic ECG of a patient with AF. What are the features of an ECG with AF? Anyone can quickly say if they know.
Irregularly irregular.
Absolutely. So how do you know it's irregularly irregular looking at this ECG?
The complex, the QRS complex.
Yeah, absolutely. Yeah. So if you just look at the QRS complexes, a simple way of just knowing is just look at how many big squares there are between the R waves, and it's clearly different from each wave to each wave. So you definitely know it's irregularly irregular, and there's no P wave. So that's basically AF. Okay. So coming on to the management. Okay, so I've written a lot here about rhythm control, anticoagulation, etc. But I've sort of highlighted in red what we need to do from an F1 perspective. And that's really just doing your AT assessment, looking for any causes for that rise in the heart rate. So, you know, what's the fluid status like? Anything else in breathing or circulation that's abnormal that you can correct? Give them some fluid, see if they're better, that sort of thing. So just really sort of treating any underlying cause really will usually settle what's happened, because it is that cause that will have triggered their heart rate to suddenly escalate. And then you can sort of like give a sort of small start dose of beta blocker or sort of digoxin as well. I double check with someone as well, just in case. I double check with, you know, like a senior who's around, or an SHO or someone. Just tell them the history and say, I want to do this as well. I want to give them a beta blocker. Just double check with someone, but yeah, you can do that as well. Anything else you want to say for that, Steph? Anything you want to add for that?
No, I think you're right. I think treat an underlying cause, because there probably is one, and then, like you say, so as a general rule, we give more beta blockers if their blood pressure's okay, and we give digoxin if their blood pressure's not okay, making sure they've not got any contraindications or nothing else is going on. But I think you can be a bit pressured to rate control people sometimes, but if they've got an underlying cause like the hypovolemic, or they're anemic, or they've got, I don't know, a pneumonia, you can be a bit pressured to rate control them because the numbers look bad, but try not to get down that path. Try and treat the cause first, because all you're going to do is kind of mess with their body's natural response to the infection or to the hypovolemia. So yeah, brilliant. So just, yeah, treat the cause, and then if there's no cause, then yeah, beta blocker or digoxin probably be the top two. We don't really use calcium channel blockers that much, contraindicated, and unless beta blocker is contraindicated, but you can usually just increase the dose of whatever they're on, and that usually does the job. So
yeah, definitely, absolutely. So thanks. So okay, so and then I've got the sort of generic management of the of AF, where you can do sort of like cardioversion, but again, this is sort of like specialist stuff that I don't think that anyone would expect an F1 to do on their own at all. Okay, so coming on to the last two scenarios, which are fairly quick. So we've got a 70-year-old with a previous CABG and heart failure, develops sudden shortness of breath, is desaturating, and the rest rate is 24. So that's the scenario. What do we think is going on? Any ideas? So the patient desaturating, they've got heart failure, developed sudden shortness of breath, rest rates are high. It's a picture of pulmonary edema, essentially. So, okay, causes of pulmonary edema. Anyone know any causes? Any causes at all? There's probably a lot of causes.
Heart failure.
Yeah, exactly. Yeah. So yeah, heart failure, ischemic heart disease, that sort of thing. Yeah.
It's okay.
No worries. Okay, yeah. So there's a sort of some causes there. of pulmonary edema. And then you can see on some investigations of what pulmonary edema looks like. And I think I've got a few slides on chest x-ray to see. So if I just move this. Okay, so yeah, on the left there's no edema, and then we can see all the way on the right, we've got significant edema. It's like it builds up as you go along. And you can see sort of like the alveolar shadowing on the chest x-rays on the right. And, clearly a picture of pulmonary edema. Any other particular features that are apparent on a chest x-ray with a patient who has pulmonary edema?
Claustrophrenic angle.
Yeah, you can see, the claustrophrenic angle. Yeah, what about it?
It wouldn't be pointy, it would be a bit curvy in a way.
Yeah, absolutely. You can get that for sure. Anything else? So this is another good example. So as you can see, there's clearly cardiomegaly there. It should be, I think the heart should usually be a third of the width of the lungs in a chest x-ray, but here it's clearly more than that. And like you said, the claustrophrenic angles are not very clear there. There's some pleural effusion there, and there's some alveolar shadowing and some other features there as well. So that's what you can see on a chest x-ray for someone with pulmonary edema. So going for the initial management, again, A to E assessment. So I mentioned that the patient was desaturating and was a bit breathless. The respirate was a bit high. So, you definitely do give them some oxygen in your A to E assessment, carry out a thorough assessment. And then anything particular that you would do, I've listed here in the sort of in the points there. So you can sit the patient up, give them all oxygen. In this case, you need to give them because the saturation is like 90%. You give some furosemide for pulmonary edema. So you can give like a stat dose of furosemide, 40 milligrams. I'm still a bit new, obviously, so I'm just a bit hesitant sometimes at how much furosemide to give, but I think it's quite safe to give 40 milligrams of furosemide IV. And I've seen it given quite a lot in this sort of situation. So there's the sort of interventions you can give in this sort of situation for pulmonary edema. And obviously, I've not written it here, but review with someone, inform your seniors about it as well.
Yeah, I would agree. 40 milligrams is a good starting dose. You can, and most of the time, if we review as a senior, we just give more.
Yeah.
And then the only other things would be like obviously GTN, CPAP, that kind of thing.
Yeah.
That would probably be when you're kind of talking to intensive care about the patient. But yeah, 40 milligrams is perfectly reasonable start.
Brilliant. Okay. So then coming on to the final quick scenario. So it's the same patient as before. You've treated them earlier for pulmonary edema, but now they're worsening. And how they're worsening? The breathlessness. They're more breathless now. The saturations have dropped even further. So you've given them 15 liters non-rebreathe, but they're still sort of saturating 89, 90%. The blood pressure is dropping to below 90 on systolic. They've got a raised JVP. Basically this patient is quite unwell. They're quite unwell and they're shutting down sort of thing. And you probably need urgent senior help here at this point. And this is most like a cardiogenic shock. And I put a definition there, and some causes of cardiogenic shock, such as like this patient might just be post-MI, a heart failure. We know they've got heart failure, that sort of thing, can go into sort of a cardiogenic shock. Okay, so the management essentially is for cardiogenic shock, from an F1 perspective anyway, is just to do the A to E assessment, which I know we've hammered all session, but this really is everything you do as an F1, is an A to E assessment. Just literally do that, give oxygen, reassess until you get senior help. Get the IV access, get some bloods, get some monitoring, ECG, that sort of thing. The desaturating, get an ABG, and sort of just continue to do that A to E assessment. And usually seniors will arrive and sort of take over management. But that's what's expected, certainly from an F1 perspective. Right, okay. So I think that was it really. Here's some references, just some good sort of like resources I use sometimes. Definitely the Oxford Handbook, Nice CKS is good. Mind the Bleep is a good website just to have a look at. Patient UK as well. These are some good apps that I have on my phone that help me sometimes in these sort of situations. So yeah, I guess the main takeaway from today's sort of quick talk and session is that always do an A to E assessment. always bleep someone and ask a senior, even if you're unsure on something small, particularly early on. It's always important just to sort of like, and people are very friendly, as Steph said, you know, they don't mind at all. You know, Steph wouldn't mind. I don't think anyone else minds when you bleep them and ask them for help. You know, they'll probably be happier that they know that patients are safe with the FY1 rather than, you know, the FY1 doing anything by themselves. So yeah, always do an ATE assessment and sort of like always ask for advice and help from seniors. Any questions? Steph, because I'll probably won't know.
Just think, well, I'll wait and see if there's any questions yet. So really good advice there. I think, you know, escalate early. And as you get more experience, you'll feel like you can manage more things on your own before asking for help, and you'll know a bit what to do better. But, you know, if you're ever unsure, then yeah, escalate. That's the important message. Anyone, any questions about anything to do with anything? Are there differences between, either is okay, Bobby, so I can't say it, so I'm not, budesonide and frusemide, they're either are okay. So 1 milligram of budesonide is the same as frusemide, 40 milligrams oral dose. Budesonide you can't give IV, so that would be the difference. So in these situations, you'd be given IV frusemide because 1, it works faster, and 2, they can get like bowel edema as well, so that affects the absorption of the frusemide. So it's always best to give it IV because you know they're definitely going to get it. But yeah, there isn't really any difference. I think people tend to get switched to budesonide if they're on quite high doses of frusemide, because you can give kind of 2-3 milligrams of budesonide tablets smaller and things for the people to have. So that tends to be the reason why we give that instead. Anything else? Any other questions? Just general stuff or about the presentation? No?
Well,
okay, well, if you do have any questions, you can always email me another time. I'm just going to put the link in the chat now for the feedback form. So if everyone could kindly complete that. And yeah, and everyone have a nice evening. I've got to go and get ready for my night shift, so not as fun for me. Can we get a recording? So all the recordings go on our website, so you should be able to access the recording via the website. Yeah. All right, I will stop recording then and then.